Welcome to episode 2 of the TVN2gether video series, 7 Things You Need to Know About Pressure Ulcer Prevention. Now I'm going to hand you over to Elaine and Siobhan, who today are going to discuss skin inspection. Elaine Bethel is the lead nurse for tissue viability for the Royal Orthopaedic Hospital in Birmingham, and Siobhan McCullough is the lead nurse for tissue viability at University Hospital Plymouth. Over to you, ladies.
Thank you, Jenny. My name is Elaine and I'm going to be talking about skin inspection with Siobhan. Skin inspection is all about early inspection. Early inspection means early detection. Now this session is aimed at anybody who is caring for anyone with or at risk of developing a pressure sore. You could be a carer, a nurse, an allied health care professional, a member of family caring for somebody. Anybody who thinks this session may be useful. So what my session is aimed at, and Siobhan will follow on, is what is a pressure ulcer? What do we mean by it? What is non-blanchable erythema, and what is the difference from blanching erythema? And what do I mean by purple skin may be ulcers, not bruises? Bruises are purple, so it's really important that we understand the difference. We're also going to cover a suspected deep tissue injury and apples and pressure ulcers. What's the link? All will be revealed. A pressure ulcer is localised damage to the skin and underlying tissues, usually over a bony prominence or related to a medical or other device, such as a plaster cast if you've broke your arm, a neck brace if you've hurt your neck, or a spinal brace if you've had surgery, or those wonderful looking anti-embolic stockings. They usually result from sustained pressure or pressure associated with shear if you slip down the chair. The damage can be present as intact skin, which can be difficult, and that's the main aim of this session, or an open ulcer, and it can be very, very painful. You or your patients may know them as bed sores, but it's important to remember that you can get bed sores sitting out in a chair. I tend to call intact skin pressure damage. You probably know them or refer to them more as pressure sores. The Americans use pressure injuries, and those of us that are oldies but goodies remember decubitus ulcers, which means to lie down. I said earlier, skin inspection means early inspection. Early inspection means early detection, and you've already had a session on assessment. It's about being a detective, a CSI. It's really important to get deep down and inspect and look at our patients carefully. In hospital, we tend to use pen torches to have a look at our patient's skin. What do we mean by category 1 pressure ulcer? It's very basically redness of intact skin. And usually it's persistent and it's a different temperature and colour to the surrounding skin. What you may find is that you lose a little bit of sensation and itching, and I'll try and explain that in a little bit more detail. The way that we test for blanching is we can use a clear instrument or tool. We wouldn't be using the fob that you can see here because of infection control purposes, but basically you can see how you press the skin. I'm going to demonstrate using these apples. If I was to press the skin, if I'd cross my legs and uncross my legs, I'd have a red area. So I'm pressing the skin. When I release and demonstrate capillary refill, you can see a white area, and that is normal. If it stays red, then we have the beginning of a pressure ulcer, a category 1 pressure ulcer, which indicates damage. And that redness, that area of damage, is the tip of the iceberg. And you can see from this slide here some examples. A red heel, the slide in the middle. Hopefully we press it for blanching. If we offload it, remove the pressure for a period of time, that will go away. Some of you may have got pressure damage from your sunglasses over the summer, over your ears or on your nose. Those of us in hospital at the moment are tending to get very sore ears, or many of you too, wearing your masks out and about. And then sadly you can see some of our colleagues in the corner during the COVID outbreak who got sustained pressure damage from their PPE gear that they were wearing. Very sore, very painful. Just because there's no wound doesn't mean it's not sore and it's not damage. What we also need to do when we're looking at the skin is we need to be looking very carefully. Purple skin is more than a bruise. I said earlier, pressure ulcers occur usually over bony prominences. So if you've got a bruise over that area, it's indicating there's some damage with the skin. Unfortunately, we have to be a little bit invasive with our patients in order to inspect the skin properly and deeper. And it's really important that we explain to our patients what we're doing and why we're doing it. The purple ulcers are suspected deep tissue injuries, suspected deep. So even though the skin is intact, potentially there is a lot of damage deep down. And again, you can see here, there's somebody's back, somebody's heel. That's not red, that's not going to go away. And to help you understand that, I'm going to demonstrate this using my apples to ulcers. We have a category 1 pressure ulcer. I take a little bite and it's a category 2, fairly superficial, will heal quickly. Bigger bite, a category 3, and I take a big bite and I'm through to muscle, tendon and bone, and that's where I've got the pips and the apple cup and I spit it out. It's not nice. My suspected deep tissue injury, think about an apple and you've got that little bruise and you're really hungry and you just think, I'll just have a little bite. You take a little bite out of it and oh my goodness me, disgusting, it's sour, it's horrible. That bruising is actually deeper than you think. So until you have a look at it or you observe and see how that bruise is going to develop, whether it's going to absorb or it's going to be deeper, it's really important to keep an eye on it. And then we have the red, the persistently black apple, which is your deep and ungradable apple. And this is where you have a very deep and unstageable pressure ulcer, very hard. You cannot tell the depth of it, but what you do know is that it is a very deep pressure ulcer. And again, if we use the apple analogy, you can see it's hard, you can knock on it, you've got a very, very hard heel. There's a lot of damage underneath there. And again, some examples here. It may be black or it may be thick, horrible slough. Ugh, that apple's gone really nasty and horrible inside. You would not want to eat it. We can use mirrors to help us inspect the skin. And I use one in my trust. I have orthopaedic patients and I can use the mirror to sometimes get behind the skin. It's not ideal, but it gives me a little bit of an idea. I can get an idea of the colour of the skin and the hue of the skin. And they are available online if you want them. So just remember, purple areas are not always bruises. If it's a pressure ulcer, it could be a suspected deep tissue injury, and just remember your apples biting into a horrible bruised apple. Thank you. I'm now going to hand you over to Siobhan, who will talk a little bit in more detail about some of the other aspects of the elements I've been talking about.
Thanks, Elaine. My name's Siobhan. I'm just going to carry on with the acronym of skin inspection and just covering what a category 1 pressure ulcer is. So very similar to the vein of what Elaine was discussing, it really is about early identification and that absolutely anybody can look for the skin and look for early stage pressure damage. So looking at what a category 1 pressure ulcer is, as Elaine is already touched upon, it is non-blanching erythema of intact skin, which is a very fancy, smanchy way of saying discoloured skin. What a lot of people don't know is how long it can take for a category 1 pressure ulcer to start. So if any of you have sat on a hard surface for a long period of time, just like blinking, you will reposition yourself. As around your pelvis, around where you're sitting, down on your sitting bones, your ischial-tuberosity, as tissue hypoxia starts to creep in there because the capillaries are being compressed, you'll get a little signal to your brain saying you need to move. And automatically, you'll move your bottom, you'll move your position in the chair. A lot of our patients won't get that signal. So just simply knowing that it's something which we're doing day to day without even thinking, like blinking, remembering a lot of our patients can't do that. It really is important to realise that can happen very rapidly. So there is an increased risk for people that are immobile. that are incontinent, that have a lack of that sensory perception, have poor nutrition and hydration, and have medical conditions that affect the blood flow. We've talked about very simple techniques to look for category 1. We get discoloration of the skin for many reasons. Like Elaine said, if you have been on the phone for a long time, if you put the phone down, you have a look at your colleague's ear, it'll be starting to go a wee bit red. But if they gave it a squeeze, you'd see that it might be pinking up again after being squeezed. So that's blanching erythema. What we're looking for in non-blanching is where you're not getting that reperfusion of the blood supply just underneath the surface of the skin. And that's why we use this very, very simple technique to check, which is compressing the area that's red for a few seconds, releasing, and if it stays red, it is a category 1 or grade 1 pressure ulcer. At this point, for us tissue viability nurses, this is just as urgent as a deeper tissue injury would be, because what we now know is that you can potentially reperfuse that area without that skin ever breaking down. So that might not seem like big news to you, but if we look at the next picture, which is a picture of a grade 4 pressure ulcer, every single grade 4 pressure ulcer will start with the beginning of tissue hypoxia, be it at the bottom of the surface, so between the muscle and bone interface, or from the external, so from the pressure coming from the top of the skin and working its way down. They'll all start with the beginning of tissue hypoxia. So it's really important for people to remember that although at a category 3 and 4 pressure ulcer, it's very serious and everyone's involved, absolutely any of us can check that early stage pressure damage, as in the picture here on the left, and see if there's anything else that we can do to prevent that getting any worse, but ultimately to offload immediately. So what can be confusing here when we talk about discoloration of the skin for a non-blanching erythema or category or grade 1 pressure ulcer is that a suspected deep tissue injury, which is what it says on the tin, we suspect the injury is a lot deeper into the structures of the skin, they are both intact and they're both discoloured. So there is a concern about missing what is a SDTI, because people may think it is a category 1. Guys, it's very difficult to categorise pressure ulcers at this stage, so always ask for that second opinion. But if you remember that if we catch a category 1 quick enough and simply offload, we might start getting that healing underneath the surface of the skin structure, do that first and then ask somebody for a second opinion. Where the damage is done at a deeper structure, it may not heal as rapidly as it would do as a grade 1. So don't worry too much about that. That it is very difficult to categorise. The research supports us with that. It's called poor inter-rater reliability. It means that I may say it's an SDTI, your colleague might say it's a grade or category 1. And what the research shows is that actually there is that discrepancy, because it isn't what it looks like in the textbooks when you're learning about pressure damage stages. It is very individualised. But as a rule of thumb, for category 1, anybody and everybody can identify discoloured skin, anybody and everybody can do a blanching technique, and everybody can potentially offload that area until you get that advice. So offload and alert. It is a very simple message, and as a result, there's been some fantastic campaigns over the years that we've used to try and raise awareness, not just to our patients and medical staff and allied health professionals, but most importantly to carers and to patients or residents themselves. Because at the end of the day, it's their skin, and we need to be able to inform people what a category 1 is so that they can check themselves where they can, but also that we get that rapid intervention. It is carers predominantly now, informal and formal, that will have access to somebody's skin that may be vulnerable. So really upskilling them and their knowledge will potentially reduce there being deeper tissue injuries, because by the time nurses or medical staff are involved, the damage is already quite extensively done. So it really is about early identification. So there has been some great resources. One of the ones that you may or may not have heard of is React to Red, which has been fantastic. It was around since 2011, 2012. It's a very simple message. And I always looked at it like the message for the meningitis campaign, of where you get a rash. If any of you've got children or grandchildren, or you see a rash, I don't know if you know, but many people will go and check to see if that blanches underneath the glass. And if the rash doesn't disappear, we might be thinking meningitis, and we might be going to A&E or to our GP. So under that kind of context, that's kind of where React to Red can work as well, because where we blanch that discoloured red area, if it doesn't disappear under pressure, we might be thinking we need to offload and alert. So it was a very powerful message, and it is still out there. The only limitation to React to Red is for that of non-Caucasian skin. So to give you an example, we've got the S-Skin bundle, which some of you may or may not have seen, which is kind of our gold standard prevention care plan. And skin assessment is very much part of that, and React to Red is, but we must remember that on the darker toned skin, it's harder to pick up on. And so React to Red isn't really going to work for darker tones of skin, where the colours may be slightly different. And I'll go through what the other signs are to look for on darker skin. So on all skin, the area may be getting quite hard from the inflammation response to the tissue hypoxia. The area may be getting quite hard on touch. The area may be hot for the same reason of the inflammation response. What you can do for darker skin, if it is a bit hard, it is getting a bit hot, but you're not sure, and they've been sitting on that bottom for a while, or on the hip, or wherever they've been lying on the area you're seeing or suspecting a grade 1 pressure ulcer, just offload them if you can, for a few minutes, up to 10 minutes, and then go back and touch that area compared to other areas of their body. If it's still hot, there's still that response, you may suspect that there might be some damage there. They may have a pain response. Quite often my patients would say to me, just as simply, nurse, my bottom sore or my heel sore. Some complain of pins and needles in that area, which makes sense if you've got that tissue hypoxia. They're trying to get that nerve response to say offload, offload. Some patients will complain of that. There may be some swelling and some edema around the inflammation area. And from what I've personally seen, is the area can be kind of bluish, purplish or violet in colour. So a little bit more like a hematoma, like a blood blister. And depending how dark the skin is, it's how easier you may be able to visually see that. So there is a really good book that was out this year by Malone McQuandy, who is a medical student, who wrote a book called Mind the Gap. And he mentioned about erythema looking shiny on darker skin, and it may have a sort of burgundy undertone. We don't have an awful lot of pictures or literature out there about category or grade 1 pressure ulcers and darker skin tones. So it's something which we really need to educate everybody about. So what can you do? What can you take away from these short videos that we're making, which is really about raising awareness for everybody? So if you remember that meningitis campaign of if you see non-blanching erythema or you suspect, there is no antibiotic that's going to help, there's no wound dressing, you don't need to swab, just offload that area and think of that blood flow being allowed to return to that area and start regenerating that skin structure. So offload and alert. You can raise awareness of this to everybody, especially to carers and patients themselves. Remember, on darker skin tones, there's something called a Fitzpatrick skin scale, which is the picture I showed you before, and that's the different shades of skin that you can get, that you can educate your public and raise awareness to carers that are looking after anybody with darker skin tones. Remember, carers are the key preventers. They're the ones that are going to see this first. I started as a carer in the community. I remember seeing discoloration skin, and I remember having no idea what it was that I was looking at and referring it on. But that time to referring it to the next person that's going to visit might be too late. It might be a grade or category 2 at that point. So think meningitis campaign. Don't forget to get involved if you are on Twitter on hashtag Stop the Pressure for this year's International Stop the Pressure Day on the 19th of November, which all of this is leading up to. There are so many free resources for you to look for yourself, but also to share with your patients. Allied health professionals can get involved. Anybody and everybody can stop the pressure. And that's really the message about early stage skin inspection. So I hope this has helped. Please don't forget to get involved and sign up to the TVN2gether YouTube channel, where there is so much information and these videos will be there for you to access.
Thanks, Elaine and Siobhan. Now you'll notice the terms category, stage and grade are used interchangeably, and this depends on where you are in the UK. What doesn't change, however, is the 6 grades of pressure ulcer. Now, this is European guidelines, and Elaine has talked about how we grade pressure ulcers based on the different depths of tissue destruction. Now, where it gets a little bit tricky is between a category 1 and a suspected deep tissue injury, because these 2 out of the 6 grades of pressure ulcer is where the skin is still intact. So I hope this video has helped distinguish between those 2 grades of pressure ulcer. Now join us next week in episode 3 for Kirsty and Karen, who are going to discuss support services and the equipment you might want to use whilst offloading the pressure for your patients.